So the further branches of the spinal nerves. Now we've dealt with the roots, right? The dorsal root, and we dealt with the ventral root. We also dealt with the spinal nerve. But things are changing a little bit, okay? Now I'm just going to, oh here, I'll show you again. So this is our spinal cord, cross-section of the spinal cord. Probably all drawn this in your sleep now, right? Okay. And then we have this. So this is your dorsal root. Here's the ventral root. Right, and this is your dorsal root ganglion, right? Now, you remember how I said this is your spinal nerve? All right, and you goes out like this? Well, I lied to you. I lied to you. The spinal nerve is very short. It's only here. Then what happens is there's going to be something coming out here. Well, it kind of wraps around here, and another one that comes up here. And there's another thing that goes this way. So this is your spinal nerve. It's very short. Okay? There's our dorsal root here, ventral root here. And then you have a few other branches, or rami, so to say. One ramus or many rami. We have the ventral rami, because remember, this is going to be posterior or dorsal. This is going to be anterior or ventral. I'm sorry, this is going to be this is your dorsal root, not ventral. Dorsal root. I'm sorry, dorsal rami. You'll see the picture come out. So the dorsal ramus. This is going to be our ventral. Right, it's small for you guys. It's not good. Ventral ramus. Okay. These two over here, this one and this one, are going to be our communicating rami. And it's going to connect with the autonomic nervous system, specifically part of the sympathetic. So let me show you. I know I'm saying a lot here. It'll make sense with this picture here. This is what I'm trying to draw for you. I think this is probably worth better, right? So here's the dorsal root up here, the dorsal root ganglion. Here's the ventral root. That's the spinal nerve. You have a dorsal ramus that goes up, a ventral ramus that kind of goes around here. Here's the communicating rami leading to what we call the sympathetic ganglion. And then this will lead to the autonomic nerve, might be the meningeal nerve. You'll see when we get into that. So this is a close-up of it, but let's bring it out a little bit. All right? You really can't, well, here, because it's underneath all the coverings. So there's the dorsal root and the ventral root. That's the spinal nerve over here, but then you have a branch that goes up. That's the dorsal ramus. The ventral ramus will go this way and kind of go around and hug, you'll see the next picture, hug around where your abdominal wall is. There's the communicating rami that goes to the sympathetic chain ganglion, okay? So you get really, see, this is even better. You could actually, so there's a dorsal ramus going up. Here's the ventral ramus going around here. That's your thoracic cavity. If it's lower, it's going to be your abdominal cavity. You see how it's going this way? Okay? Then you have these communicating rami. Now, does that make sense so far? All right, it's anatomy. It shouldn't be so bad. Okay? But I like this picture because you could actually appreciate what why we call this a sympathetic chain ganglion. Here's the communicating rami that's coming off of here, 2 of them. And they go into this big bulge, which is going to be our sympathetic ganglion. But the sympathetic ganglion is connected to the next one down below and the next one above it. So that's why we call this the sympathetic chain ganglion, because it's kind of like in a chain. Okay? Questions on that? Shouldn't be bad, it's just anatomy. We haven't even talked about the physiology yet. Physiology students really go a little crazy, all right? But the anatomy shouldn't be bad. We're just adding more words to your vocabulary, okay? The other thing I would just want to mention is make sure you understand when we get into the autonomic nervous system that the sympathetic chain is very close to where the spinal cord is. It doesn't move out. Like, here's where the sympathetic chain is. It's pretty close. It's not that it goes out here like a spinal cord would, or a spinal nerve, or the rami, let's say the ventral ramus or the dorsal ramus. It's not going out there. It kind of stays pretty close to the vertebral column. Okay? All right. All right, so now let's talk about nerve plexes. Okay? This is where, as I explained to you, we have the brain, right? You got the cerebellum and the spinal cord. But then the nerves, we have C1, C2, C3, C4, C5, all the way down, right? On the other side too. And plexes, or plexus, means that these nerves will actually converge with each other. See what I mean? Making a spider web. So the nerve plexes generalizations, they come from the ventral rami branch, all right, the ones that are coming out this way, not the dorsal, ventral. And we have 5 nerve plexuses that you need to know. You do not have to map them out. If you want to map them out, go to medical school, all right? But there are certain things I want you to know. In other words, well, you'll see, okay? All have sensory and motor parts. This one, the cervical plexus, is going to come from a derivation of C1 to C5. C1 to C5 will make up the cervical plexus. You won't have to draw it out, but you do need to know which ones they're going to be part of, okay? We also have the brachial plexus that allows us to move our fingers in the right way in the arms. That's going to be coming from nerve roots C5 to T1. So C5, C6, C7, C8, T1. We also have the lumbar plexus that is going to be a part, well, it's going to use nerve roots L1 to L4. We have the sacral plexus that's L4 to S3. L4, L5, S1, S2, S3. And the last one is the coccygeal plexus, which is S4, 5, and like I said, we have a coccygeal nerve, but there's only one of them. So we can't call it C1 because you're going to get mixed up with cervical nerve C1. So we call the coccygeal nerve C0. Okay? So the coccygeal plexus is made up of 3 nerve roots, S4, S5, and C0. Okay? Now, what do you need to know about each one? If Dr. Gamarlo says you don't have to map them out, you don't have to map them out, but there are certain things you need to know about them. For instance, the cervical plexus, this is what you need to know about it. It's from C1 to C5 and supplies the neck and posterior portion of your head. One of the nerves that you do need to know is the phrenic nerve, which is made up of C3, 4, 5 in this part here. And it innervates the diaphragm. Whenever you see phrenic, think diaphragm, with the phrenic artery, phrenic nerve, and so forth. If you sever any of the phrenic nerve, you won't breathe. The phrenic nerve is vital to breathe. So I usually say C3, 4, 5 keeps the diaphragm alive. Okay? This is what it looks like. This is what I'm asking you not to memorize. Go to medical school or take neuroscience and see how you have to come up with all this and how you have to draw it out. I do have mnemonics to know this, but I'm not going to ask you to know all this mapping or spider web. Okay? But C3, 4, 5 keeps the diaphragm alive. It will make this phrenic nerve. There's other nerves in here. You don't have to worry about those. Phrenic nerve, I think you should. Okay? Not bad? All right. Brachial plexus. This is what you need to know about it. C5 to T1, located in the armpit, supplies the neck and shoulder muscles and the entire upper extremity. These are the nerves you should know. Axillary nerve, radial nerve, musculocutaneous, ulnar, and median. We talked about the median nerve once before dealing with carpal tunnel syndrome. Okay? This is what it looks like. And again, I won't ask you to draw it out, but some of you may be really curious about how that is, and my suggestion is to do it after the course is over. Okay? But that's where they all are. Now this is what we're concerned about in obstetrics, because when a baby comes out vaginally, this is probably the biggest of all the obstetrical lawsuits. When a baby comes out, we are to let the baby come out, and we're just supposed to guide the baby out. Some doctors, if the baby is too big and the pelvis is too small, or the pelvis is too small and the baby's too big, or not too big, but it's just a small pelvis, then there's going to be some issues. The head comes out, but the shoulders are very broad. All right? I mean, look at the head here, but then we have to worry about the shoulders, which is bigger than the head. So the head popping out is one thing. Then we have to deal with something called shoulder dystocia, meaning like a difficulty in delivering the shoulders. All right? If that happens, it's happened to me probably about 8 times in 3,000 babies. And it's very, very scary. There's nothing that a doctor's done to cause this, or a woman or a baby to cause this, but the shoulder gets stuck. And when a doctor's pulling on that, we shouldn't be pulling, we should be guiding it, but it's very scary. It probably only will last about 30 seconds, but it will feel like 4 hours, because we have a nurse that's usually, plotting our forehead here and stuff. But when it comes out, what's happening, think about it, you're going to be pulling the head and stretching all these nerves that are coming down here. And they would have a lot of palsies is what's coming out. All right? We could have brachial plexus palsy where the wrist drops because there's something wrong with some of these injuries to the brachial plexus. All right? If they're being overly stretched. It's like a wrist drop. You lift it up and it just drops. And they sometimes call it waiter's tip because it's like you're asking for a tip like this. All right, I know it sounds bad, but we see that. We also see median nerve palsies and things like this. They have like, you've probably seen like a child walking like this. It's probably a brachial plexus injury. All right, it could be cerebral palsy for that too. Also, the musculocutaneous deals with a muscle that's going to keep the scapula down. And the way you can see it is you put your hands like this, the scapula flips up. And we say it's a winged scapula. But all these, I won't ask you about these injuries at all. I'm just saying this is why you need to know about the brachial plexus, at least some of the nerves over there, because it's pretty, I wouldn't say it's common, but it's not uncommon to see this kind of stuff. If you're going to be working with doctors and children, if you're doing occupational therapy and stuff, you should know about some of these, but, okay? All right, lumbar plexus. It's commonly called the lumbar sacral plexus because of the close relationship that they have with the sacral plexus. But this is going to be L1 to L4, supplies the lower abdominal wall, external genitalia, and the anterior portion of the lower extremity, anterior. And you're going to see some words on here that should ring bells to you. All right? You got the obturator nerve. Can you guess what hole that goes through in the pelvis?
The obturator
Obturator foramen, yeah. Okay? So the names will start ringing bells for you. All right? The femoral nerve, all right, going to the femur, right? Tibial nerve, common fibular, also known as peroneal. And it does these things here. Okay? So you can see it over here, what they do. Again, I'm not going to ask you to map it out, but I put it here just to be complete. We also have the sacral plexus, but it could be a part of the lumbar sacral plexus. It's L4 to S3. So L4, L5, S1, 2, and 3. And it supplies the remainder of the lower trunk and also the lower extremity, whatever's left. You have two nerves over here. Sciatic nerve, right? We dealt with the greater sciatic notch. It's going to ride along that. Now, the sciatic nerve is the largest and longest nerve in our body, okay? And it's actually made up of, you should know this, hint, hint, it's made up of two nerves, the ones we just showed before. The tibial nerve and the common fibular or peroneal nerve. They are made up of that. They kind of fuse together and make up the sciatic nerve. You've heard of sciatica? We're going to talk about that too. It also makes something called the pudendal nerve, that's going to deal with external genitalia. Okay? We usually, as an obstetrician, we usually numb that area if we're going to cut like an episiotomy or something, make the hole bigger for the baby to come through. And that's the nerve that'll numb in that area. And the sacral plexus is there. Again, you won't have to draw it out. Okay? The coccygeal plexus, S4, 5, and C0, supplies the pelvic floor. It's also going to contribute to the pudendal nerve. Okay? That's all there. All right, questions about that? Again, it's not, it's whatever's on these slides here, not too much of the pictures. The pictures are there just as an FYI so you know what I'm talking about. Okay? But you can see over here, here's a sciatic nerve. It's made up of two nerves. It's this combination. You got the common fibular and you got the tibial. This thick one is this whole sciatic nerve. Okay? Okay. Dermatomes. This is interesting stuff. All right? Well, let me show you what this is, and I'll talk about a few conditions of this. Dermatomes is specific areas on the skin that's innervated by spinal nerves, except for C1. Okay? So in other words, if I touch here, there's a map of your body, it's called a Dermatome Map. If I touch here, and I know what that map is, and you feel me over there, then I know that that spinal nerve is getting sensory, so I know that's working. And what's happening here is all cranial spinal nerves receive specific skin sensations. And they're concerned, the dermatomes are only concerned with sensory, not motor. All right? So you have this dermatome map that doctors or medical professionals could have an idea that, geez, he's not feeling anything below the elbow on this part of the arm, not this part, but on this part, and you have an idea of what nerves are compromised. Okay? So it helps medical professionals to figure out where in the spinal cord without doing major surgery or without doing any kind of expensive instrumentation to figure out what's going on with that person. At least you get some idea what's going on. Okay? So an injury to the spinal nerve will cause sensory loss, i.e. anesthesia, in the skin supplied by the sensory roots, i.e. the dermatome. And you will get flaccid paralysis of the muscles, right? We kind of talked about that already. If it's the lower motor neuron. So this is what the dermatome map is. And again, I am not going to ask you to memorize this. If you're going to be a medical professional, you will have to memorize this one time in your life. All right? If you don't use it, you kind of lose it. All right? So I have it where, for myself, I used to know all this, where they all go. But now I just know certain areas. Like where the nipples are, that's T4. Where the belly button is T10. So if I know they can't feel something that's in between, then I have an idea, well, it's going to be between T4 and T10. Do you see what I mean? Like I have some idea, but before, when I had to memorize this, I had to know it all. But you don't. You could just get an idea of what's going on. All right? But every part of the skin is going to be related to the spinal cord. If I touch over here, like your thumb, then and you feel that, then I know that C6 is working. Does that make sense? It gives you an idea of what's going on here. It's pretty interesting. All right? And there's also a division that goes straight down because we have like T7 on the left and T7 on the other side, right? The spinal nerves. There's one on one side and one on the other. So let's do this little, well, I know you do this, but you didn't realize it. So next time it happens, experiment with yourself. Looking over here, the yellow here is going to be controlled by the median nerve. The pink here is going to be controlled by the ulnar nerve. That would make sense to you, right? Ulnar is going to be medial to the body, right? Okay. Now, notice that the yellow here, the median nerve, is going to control, or not control, is going to receive sensory on your thumb, your index finger, your middle finger, and look at the way the ring finger is. It's split in half. The lateral side is taken care of by the median nerve, and the medial side is taken care of by the ulnar nerve. You see that? Okay. Now, how many of you, and this is a rhetorical question, how many of you are lying on your bed studying my A&P, your book is open, and you got your elbow down here, all of a sudden you feel pins and needles in your fingertips. Right? You felt that before, right? Your hand's falling asleep, right? Okay? It's not really your hand is falling asleep. Okay, that's layman terminology. What's happening is that you're pressing on a certain nerve. Okay? Or blood supply to that nerve. Either way, that nerve is being compromised somewhat. And those pins and needles are a good thing because that's telling you you're sitting on that certain nerve or blood vessel for a long amount of time. You need to move. If you don't feel those, you're going to be there for a long time. And if it's a blood vessel, then that blood vessel is not going to bring nutrients to that nerve, and the nerve will die eventually. People had strokes that can't move over. That's why you got to move them over. Does that make sense? Okay? So you have these pins and needles that are happening in your hand. But next time it happens, take a look. Give a moment. You're not going to die from it. Take a moment and feel your ring finger. And see, you know that there's pins and needles in your hand, but now you could actually divide what's going on. Are you on your median nerve or you're on your ulnar nerve, because it varies on which way you're putting pressure on it. I felt it in both places. If you could feel your lateral side, and there's no pins and needles there, of your ring finger, and then I do my medial side, and I'm like, whoa, I feel there's all these pins and needles, you know you're on your ulnar nerve. If you feel pins and needles on your lateral aspect of your ring finger, but nothing really on your medial, it's the median nerve. Okay? I know you're probably thinking, well, geez, median, it's not on the left. Well, it's in the middle, median middle. It's in between the radial and the ulnar nerve, so that's why they call it the median nerve. It's not the, don't think of medial. All right? But I know you've dealt with that before. It's kind of an interesting thing. Okay? So you can do that. And you can even see where they kind of curl up on the dorsum of the hand too, and how that actually relates. You can take a look at that. Something similar to the foot, I really don't want to go into it, but you could do that too if your foot falls asleep. And you can guess what nerve you're doing. You know, that's being, they're having those pins and needles. Okay? Now, let's talk about sciatica. Who here has heard of sciatica? Okay? Whether you heard it from about a friend or a family member or even yourself. And what happens here is referred pain because something is pressing on or damage is happening to the nerve roots that make up the sciatic nerve. That's what's going on there. And that's why they call it sciatica. Okay? So pain stems from any roots that are making up the sciatic nerve, L4 to S3. So if you had a vertebral compression onto, let's say, S2 to S3, then that's going to compress that disc, intervertebral disc, and go right and bulge out, a herniated disc, bulges out and presses against those nerve roots. Okay, now it could be something temporary where the inflammation is going to go away in about a week's time, or it could be something permanent where the vertebrae just got crushed, motor vehicle accident or whichever. So the affected nerve root will cause pain to the dermatome it innervates. Now or at least you could look at a map, the dermatome map, where, let's see, S1 or S2 or S3 go. So if you know where the dermatomes are, then it will make sense. All right? What do they usually say when they have sciatic pain? Where's the pain usually? The glute, right? So it's the back of your leg, right? The back of your butt, your bum. And it usually is running down the back of your leg. That's what they usually will say. If not, ask them. That's where you got to make a point to ask them. My best teachers were my patients, not my professors. All right? The patients were my best teachers. I would ask them questions and they would tell me, yeah, the pain is back here. I always remember, my first patient with hyperthyroidism, my first patient with lupus, because I asked them all these questions and then I just everything was in the books afterwards. I said, yeah, that patient had this. I learned from that. So ask people. If your mother or your father has sciatica, ask them, where's the pain? Use them as, I don't know how to say this, but use them as like a guinea pig if you want, and say, okay, Mom, can I just feel this, and I just want to put a needle back, not a needle, or let's say a pencil or something like that, and tell me when you feel the pins and needles. And you could actually draw out the map. I mean, don't draw it on her, but you could draw out the whole map of what's happening, and you can figure out where it's happening, right? Look at this. L4, right? So L4, L5, S1, S2, S3. So L4 is towards the front, L5 is even towards the front. They usually don't get crushed as much when we're dealing with sciatica. They can though, but we don't usually see it as often. It's more of the lower extremity. So what's going to happen is, look at where S1 is. S1 is down by the foot. S2, it's all this back of the leg. S3, the gluteus. S4 and S5, well, up to S4. Does that make sense? You can see where the referred pain would be. And you can almost draw out the map. All right? It's a pretty neat thing, actually. All right? Now, the other way you could also apply this stuff is chickenpox. Or shingles, really. Shingles and chickenpox. It's a virus. called the varicella zoster virus. Varicella is referring to chickenpox. Zoster really refers to shingles. The problem is, when children get it, they get the chickenpox, they got to stay home from school, not because the itchiness, it makes it look bad, but it can lead, if a child in the school gets the chickenpox from your child, or from anywhere for that matter, they may have a low immune system. Maybe someone who's got AIDS or something like that, and they're in school and they don't have they can't fight the infection like a healthy person would. So now you're going to be giving them this virus, okay? And this can lead to a brain infection called encephalitis, or even pneumonia. So that's why we let the kids stay at home. Now let me just also say that what is infectious, what is contagious, is if you ever had the chickenpox, there are these vesicles that almost like little blisters, and it has fluid in it. When those vesicles burst, if they burst, that fluid is what's contagious. It contains the viruses in that fluid. Once it dries out and looks all crusted, and it looks pretty bad, even though it looks bad, it's not contagious. Does that make sense? Because it's all dried out. It's not, the virus isn't there anymore, at least in the fluid there. But it takes your body to fight this infection about 2 to 3 weeks to build up the immunity. You'll learn about that in immunology. So we don't lose this virus. You get, what is that cream you put on you? Calamine, yeah, calamine lotion on there. And that just brings down like the itchiness. But the virus, it just have to, your body has to just fight it off by itself. All right, it's self-limiting. But what happens here is that as your immune system gets stronger and stronger trying to battle this thing, the virus gets scared. And it runs away. And it runs away but stays in your body, but it runs away and it stays in a dorsal root ganglion. And stays in there for decades. It knows that it will be beaten if it goes out in your bloodstream, and it stays in the dorsal root ganglion for a long amount of time. Now, which dorsal root ganglion? I don't know. I don't even know if they figured out which one, because it varies for each person. But it will sit there and stay there for decades. Then what happens, and as long as your immune system is good, they'll stay there. But once your immune system gets compromised, you have HIV, you get older. As you get older, when you're at the elderly, their immune system starts dying down a little bit. It's not as fast as what it used to be. You're on corticosteroids for certain conditions or diseases. Anything that's going to compromise your immune system. If you had chickenpox before, the sleeping giant awakens and sees that your immune system is weakened and says, we could come out and party. And what they do is that they actually will crawl out, well, not crawl, but they'll actually go out on that nerve, wherever that dorsal root ganglion is, and goes out there and will follow that dermatome pattern to wherever that dorsal root ganglion came from, or I'm saying sensory. And they get this rash that is very classic. You see this band that actually happens because it goes on the dermatomes. Not the whole thing, it'll only go on one side. Sometimes they might have, let's say, 2 or 3 area bands, so to say. Depends on what dorsal root ganglion they were hidden in. That's what we call shingles. And unfortunately with shingles, it's not very itchy. It may be itchy, but it's usually painful. Okay? Some people just have the rash and they don't even feel any pain or itchiness. Most of the time, they feel very, very much like pain. So that's how someone gets shingles. Okay? So it's either gets reactivated by immunocompromised patient, HIV, something like that. Patient is under great stress. Okay? You take my AMP1 course, you're going to be stressed. You might find yourself getting sicker than you usually would. All right, when you have a lot of stress, your immune system goes down. I know when I was in medical school, I just popped a lot of vitamins because I know I was going to be stressed during that time. So, you know, I'm not really big on vitamins per se, but an A to zinc kind of vitamin, if you're missing anything in your diet, just put one of those in. All right, it'll try and build up your immune system and other things. And like I said, as we get older, our immune system does decrease. So these are the times when shingles can pop up, okay? And I'm telling you, the dermatome, when it comes out, they're very nicely delineated along that dermatome. So you could have bands that are over here, over here, over here. It depends, you know, it could be anywhere. Even on the face, if it goes to a certain cranial nerve, okay, which is called the facial nerve, no, I'm sorry, trigeminal nerve. The trigeminal, because it has these three branches that go out, 1, 2, 3, they could actually ride along one of those and they could actually get this very nicely delineated rash on their face. Unfortunately, it's also painful. All right, so you can see here, there's this over here, there's a band that goes up. Pretty classic. All right, you can see, like, we see this band that's going up like this. This one is where they got the trigeminal nerve, but you can see it's like a straight line, you know. I mean, that could also look like a burn, but if she doesn't have any history of a burn, that she just woke up one morning and she starts seeing a rash like this, that's what that is. All right. Questions on that? Kind of an interesting thing. Okay, so that is Superman, spinal cord and spinal nerves.